It's really great to be here. I'm from New York City, so I love a good reason to come to the city and get to see my parents. And so I'm Kerry Weinberg. I'm the VP Data at League. I'm going to explain who we are a little later. I promise it won't be a sales pitch. And my talk is on the difference between expectations and reality when you apply machine learning in digital health. Oh, let's make sure this works. Okay, great. And there's some contact information if you want to get a hold of me, have any questions. Cool. So the context of my talk is with the pandemic, we've actually seen a really considerable level of adoption in digital health solutions. So that would mean we would have a lot of data to apply machine learning models to it, right? Well, there's a big difference between our expectations of what we can do and what is practical in some of those challenges. So I'll talk a little bit about how interoperability really makes this a lot more achievable, but there are still nuances in terms of how making data more unlocked. There's practical implementation that is quite different for machine learning. I'll also explain a couple different case studies in terms of how we're doing this at League that give you a picture into what that's really like, applying machine learning in digital health. And then I'll close with I think a positive outlook on the future of applying machine learning in digital health. So I presented at this conference in 2019 and I asked the following question. And so I want to ask this again and see if the answer changes. Can you please raise your hand if you're able to look up your bank account information on your phone? Okay, again, very financially responsible audience at this conference. That's consistent. Okay, and then my next question is, how many of you could look up your electronic health record on your phone, not your COVID vaccine passport, okay? How many? Okay, that number actually went up since I presented a couple years ago, which is great, but you'll notice it's a big difference. So if I want to go to a bodega and I want to look up my bank account information, my ATM balance will be the same as if I went to a Bank of America ATM. But if I got a flu vaccine in California at an urgent care, and I want to look up the last time I got that flu vaccine at an urgent care in Massachusetts, I won't necessarily be able to get that information. What's the reason for that? Well, I'm going to apologize in advance to anyone who works for Epic and Cerner, because what I'm about to say will offend you. But historically, those electronic health record vendors were disincentivized to enable interoperability of healthcare data. And here's where government regulation came in. With the Affordable Care Act, it created a requirement that payers and providers should be able to allow patients to share their data in an interoperable format. So the answer to this is FHIR. FHIR stands for Fast Healthcare Interoperability Resources. So it's a defined data standard and API specification that tells healthcare systems how to communicate with each other in terms of data. And the US government has required that patients should be able to access a core set of their health data from payers and providers. And there's been a rolling implementation and compliance timeline for this. The FHIR community is a really active one. It's one that has been focused on making this a lot more seamless, but obviously there's been challenges in terms of the implementation. So, okay, we have a format, we have an API specification, we can share data. Does this solve our problems in terms of how we can apply machine learning in digital health? Maybe. The first challenge we have is traditionally people didn't access their health digitally. I think I would wager most of you didn't book a telemedicine appointment before 2020. Most of you probably didn't work on your mental health using an app like Calm or Talkspace. And so obviously with the pandemic, we actually have seen a really considerable adoption of consumer digital health as well as wearables. But it's still not at the level that we would aspire to have if we want to be able to build the kind of models that our friends in fintech and other consumer tech are able to do. The second challenge is FHIR compliance. So, okay, the payers and providers, they're complying, but they're complying to the letter of the law. They're not going to go to the full spirit. They're going to make the core set of data available, but there's a ton of rich information that they have, which they're not necessarily going to make available. And not to mention, consumer wellness applications, non-payer and providers aren't required to make their data available in this standard. So it does create some limitation in terms of how this data can be shared. And then the last piece is FHIR was never built for machine learning. It wasn't actually the objective. The objective was to enable interoperability of data. Obviously, when you create a data standard that lets you interoperate data across health systems of record, that's really beneficial from an ML standpoint because I have a consistent ontology. I don't have to remap the different information that I'm ingesting. But the challenge is the community didn't build it with the intent to apply machine learning, and now all of us are trying to do that. So those are some of the challenges. I'm going to take a moment to just explain who League is because I've done this whole explanation on FHIR and data, and I'm going to talk about 2 case studies in terms of how our team is practically implementing machine learning in digital health and what we're experiencing. So we're a digital health platform as a service company. We have a couple of core capabilities, the ability for someone to access care, get information on their benefits, and work on their health proactively. And we make those available to our partners that range from payers to retail pharmacies to build direct-to-consumer digital health applications. So the first example that I'm going to talk about is in our work on recommending what is the next best action that a user should take to engage in their health. One of the capabilities that we have that we enable our partners to deliver in a direct-to-consumer digital health application, we call it Health Journey. It enables users to enroll in a health program or multiple health programs. Those programs you can think of are steps that users can take to work on different health goals. So maybe you want to work on managing your anxiety. Maybe you want to work on meditating more. Maybe you want to learn about how to manage your risk of diabetes. Or you're preparing for a pregnancy. Or you're trying to walk 10,000 steps every day. Those are the kinds of programs that our partners can build and users can enroll in those programs. But we want to go a step further. We want to make sure, given you've enrolled in these programs, what is the next best thing I should see in your journey? So we have a library of options that are available for users, and we want to make a recommendation. The approach that we're taking is a modification on matrix factorization. We call it matrix factorization with specification. So because we're in healthcare, interoperability is really important to us. Traditional matrix factorization only worries about latent features that you're figuring out. We want to be able to include explicit features so that we can get some sense of why the model is recommending this user is likely to take this action. We also want to have a methodology that is performant on cold starts as well as high sparsity. We can address some of the sparsity issues by using consistent features across the activities. So if a given activity is of type connected device, if a given activity is of type, work on diabetes or is related to watching a video or reading something, those are consistent features that we can utilize across the activities to help address some of the sparsity. And so the other thing to note is, okay, we want to build an ML model that is performant on this. At each step, we want to make a prediction, what is the probability the user is going to do that thing I recommend to them? But we also want it to be FHIR compliant. And that is non-trivial in the sense that we have to manage a number of different FHIR resources, data types, to make sure that we're representing it effectively. Some of our experiences in doing this. So the pro is we get to use a consistent data model. That's great. For now, we're just using data that's generated on our platform. In the future, we could utilize data that are from our partners. Our representation of a health journey, the action somebody can take in their health, it is conceptually very similar to one that's called a care plan in healthcare, which clinicians or a health coach can provide you to say, hey, you just had a surgery, here are the steps you should take. You just became you're at risk of diabetes, here are the steps you should take. So we do have an opportunity to be able to ingest data that's of a similar standard to build up our model. We haven't done that yet, so we're primarily working on the data that is generated on our platform. So we have a bit of a cold start problem because, as I mentioned, people traditionally haven't interacted in their health digitally. So you have a feedback loop. People aren't interacting in their health digitally. We don't generate that data. We can't use that data to build personalized recommendations, which means people might not be interested in the application. So there's a bit of a challenge there. And so we want to be able to make the best recommendations we can with the data we have available. I will say the methodology that we've taken is more performant on cold starts, but it's not easy. And the other challenge is because we're trying to be FHIR compliant, We need to ensure that our approach is recognized and approved from the FHIR community, and this hasn't been easy. But the benefit is, I think we've taken a number of steps to mitigate some of these challenges, and I think there's even more that we can do in this space. The second case study I'm going to talk about is analyzing connected device data. So on our platform, users connect their devices to be able to auto-complete activities that are associated with their activities. So like, I sign up for a Walk 10,000 Steps program, I walk 10,000 steps, I'm connecting my Garmin or my Apple Health or my Google device, and we're getting in that data. For now, we're focused on what we can do to surface to the user in terms of rewarding them when they complete their goals, but we're also building out the functionality to actually derive insights on this data and patterns in terms of people's behavior. I have a couple plots here. This is preliminary, so I've done some obfuscation to not provide a ton of detail, but the order of magnitude on the sample size is in the thousands. On the left-hand side, you'll see sleep wake-up times for people. Obviously, people wake up later on the weekends than on the weekdays. And then on the right-hand side, you'll see 2 weeks where it's step counts taken by users over the days of the week, Monday through Sunday. Those are 2 different weeks in the month of January, so I'd have to look at it again, but I think there was like a holiday in there, or there might have been a bad snowstorm in the area where most of the users are. What's really interesting here is that, with this, we have the opportunity to apply a number of both supervised and unsupervised techniques on this data. So these are just 2 examples of the kinds of data that we support users integrating on our platform, but there's a number more that are available. What is really exciting is that, if you just look at this can give you some sense of the kinds of behaviors people are taking. But as part of our platform, we can also get information on what people's current health risks are. We can also ask them questions. Are you feeling anxious? Are you feeling stressed? When's the last time you had a migraine? What was the severity of your migraine? And that's really powerful because then I can start to characterize what these users are doing and how it relates to their different health risks or what they're working on in terms of their health. And this, I think, is a really exciting avenue that we're exploring this year. So here's an interesting challenge associated with this. This is patient-generated health data. That's like the holy grail in healthcare. Traditionally, when people called something patient-reported outcome, it was a clinician texting you to say when you were stressed. Tell me when you're stressed. Now we're moving to, you have all these devices available to you, so we can actually get all that data on yourself. You don't have to go to the doctor necessarily. This is really valuable because it gives you a much more accurate representation of somebody's health status. And these devices are getting even more sophisticated as they go in terms of their measurement and what's connected that you can actually obtain. But what's the challenge? Who is the real source of truth? So if a user is connecting their blood pressure monitor, for example, and they're monitoring it over time, and they take their blood pressure every single day, okay, they're in a repeatable environment, and they're administering it themselves, so they won't have white coat syndrome. But on the flip side, they're administering themselves, and they're not a clinician, so maybe they're not using it consistently. If I want to use blood pressure as a criteria to recommend something to someone or alert them, which blood pressure do I use? Do I use the one that the clinician took when they went to the doctor recently? What if that's 3 months old and they take their blood pressure every single day? Who is the real source of truth? And not to mention, weight is a great example. Somebody takes their weight at home every day and you're trying to measure weight loss. People can be very creative in how they weigh themselves versus when you go to the doctor, there's a very specific way they weigh you. And that difference, I think, can be really important in terms of now if we're going to use that information to actually surface something to somebody, we want to make sure we're aligned on what the objectives are. I gave this example to my dad, and he was like, I just bring my blood pressure device to my doctor. I was like, okay, but you're not a great example of the traditional patient. What the approach that we're taking is to enable our administrators to actually define this. This is not a perfect approach, I will say that, but it is an approach that we're planning to take on, which lets the administrator decide, okay, based on the recency, the source of the data, for specific data points, I want to be able to use those to surface different content. I think in the future, it'll be really interesting to see how there's a lot more information that we can get to automatically calculate what would be more appropriate to surface to that user. But for now, this is our current approach. So I shared some of the practical challenges when we apply machine learning in digital health through our work at League, but I am really optimistic in terms of where this space is going. The first is, as a consumer, in every other part of your life on your phone, you expect personalization. But in healthcare, that's like a nice to have. Most people's way to access their health records through their provider is horrific. And most payer applications are also extremely challenging to interact with and are definitely not personalized. So as more consumers adopt digital health, we're able to generate more data that we can use to personalize the experience. And we have more new entrants that come from non-healthcare backgrounds. They're able to bring new approaches to reach people. The second thing I'm really excited about, which actually doesn't relate to League, but it could in the future, is what's called digital therapeutics. So in this concept, and machine learning hasn't yet totally been applied to this space, we're actually applying an intervention to somebody that is digital in nature, and we're observing an outcome that's clinically validated. And so people can actually be prescribed this. There's a couple solutions that are, I think, commercially available, or they're about to be approved. Pair therapeutics, click therapeutics, and really interesting treating opioid addiction, anxiety, ADHD, and other conditions. And that's just the start of a purely digital intervention, let alone adding in a biological intervention. And that's not even using machine learning. So if you can start to see a decline in somebody and intervene before there's even an issue, that I think is a really exciting promise of applying machine learning in digital health. The third example is what I call digital phenotyping. And this is related to what I was showing in terms of the sleep-wake times and the step counts. If we can characterize somebody based on their digital signature, not just one dimension of data, but multiple that are digital as well as self-reported or from other sources of truth, we can characterize somebody. What does a migraine patient look like? What does someone with early diabetes look like? And we can start to not only predict if someone's disease state is declining, we can also characterize what that looks like and be able to monitor it over time. Lastly, what I'm really excited about is digital health becoming the expectation, not the exception. And this is really critical to all of the above being achievable. I think that it's an incredible space, and in the past 2 years, we've seen a level of acceleration in adoption that most people have assumed would have taken us 10 years. So with that, we only get more data, more opportunities to get these kinds of insights and personalize the experience, and ultimately more adoption, enabling people to access their health in the way they want to. So with that, I'm happy to take any questions.